that is led by the INSPIRE Consortium with support of the European Civil Protection and Humanitarian Aid Corporation, DG ECHO. In addition, he has several publications in peer-reviewed journals, book chapters, and conference proceedings, and is a reviewer of several international and national journals on public health, medicine, and pharmacy. He's a member of the Association of Editors of Scholarly Publications in Nigeria, AHAPN, and President SIM Health Africa, that is African Society for Improved Health Delivery, with focus on health capacity and innovation. The website being www.simhealthafrica.org. He's also the convener and chair of the AHD conference, that is the African Conference on Healthcare Delivery, with our website being www.ahdconference.org, with the objective to advance sustainable value and innovation in healthcare delivery, mentor and train professionals, academics, and students in key subject areas. No doubt you agree with me that there is no one more qualified to deliver this keynote address. So please join me in welcoming Professor Ehige Enato as he delivers the keynote address. Professor Enato, please.
Yeah, thank you very much, Dr. Ejiro, for that very lengthy introduction. I'm very happy to be here and to be part of this discussion on the 2021 World Malaria Day. When the national chairman of the association contacted me, I did not hesitate in accepting because in the last 15 to 20 years, I have been an advocate of the fight against malaria, not only in Nigeria, but also internationally, having worked with several tropical disease institutes in Europe and other parts of Africa, and also being part of big projects that are attempted to improve on the surveillance, management, prevention, and treatment of malaria. So I felt that it was an opportunity again for me to re-echo some of the beliefs that it is possible for us to eliminate malaria in Nigeria and indeed Africa, and therefore thereby making the world a better place. Okay. Okay. Yeah, Pharmacist Ejiro, could you please share these slides, because I did inform the organizer that that I was going to use a small device in the presentation. As such, I will not be able to share from the handheld device.
Okay, Dr. Bello, please.
Okay. Okay, hold on.
Okay, thank you very much. Great. So next slide, please. So today's discussion, I would like us to take you through this brief outline. And I've also been told that I need to be very precise. So we'll just go straight to the point and talk around issues, talk on issue around the malaria. So next slide, please. Yeah, as we listen to the moderator of this event, and also the national chairman, and they make good references to the World Malaria Day as being marked, April 25th every year, right? So, and it's been, and this initiative has really been going on to draw world's attention to the problem of malaria. And this year, the idea is really to highlight the global efforts to end malaria, which is what everybody wants, and the need to have a sustained political commitment especially among government partners and donor agencies, and also in terms of continuing investment in malaria prevention and control, and especially as we move towards malaria elimination. This year, World Malaria Day is particularly important because it draws on two very important movements, which by the global community, one of which is unifying and build on Zero Malaria Starts With Me movement and Draw the Line Against Malaria campaign. So these two important campaigns are very important, and this year's World Malaria Day draws on those two big events. Through its theme, this year's World Malaria Day seeks to highlight the successes that some countries have recorded in the fight against malaria, which means it's doable, especially for those countries that have reached zero malaria since the year 2000. There is also an opportunity to inspire a new group of countries that have the potential to eliminate the disease by 2025, and to demonstrate, very importantly, that zero malaria is possible and is achievable. Next slide, please. So before we move on, just to quickly mention, I know this is very familiar because I assume that everyone on this Zoom meeting is a pharmacist, and of course have a thorough understanding of the disease itself. But again, I think it's important to remind ourselves that malaria still remains a febrile illness, which is characterized by fever and related symptoms, and has been with us for a very long time. You know, it's an ancient disease that has been with us, and it is caused by protozoan parasites of the Plasmodium, of which 4 species are important in human malaria. And among these 4 species, the P. falciparum has remained the most stubborn and of all of them, and which is more predominant in Africa. Malaria itself is transmitted through the bites of female Anopheles mosquitoes, and Anopheles gambiae, which is the mosquito that is also very prevalent in West Africa, right? And also very resilient, you know, of all the species, you know, which makes it a double jeopardy for us, for those of us who live in Africa. And then, of course, we know that malaria has continued to remain a tropical disease. The burden of malaria is huge, and that's why we are devoting our time, you know, to addressing the issue of malaria. And malaria has continued to remain a major public health problem and a negative factor in the socio-economic development in our country, and indeed in Africa. And as we listen, as we listen to the earlier 2 speakers, they gave very good statistics of the current situation with regard to malaria cases and deaths. And then when you look at the picture, you see that it's not very favorable, right? More so that, you know, majority of this burden of malaria reside in sub-Saharan Africa, especially with regards to the under 5 children, and as well as the pregnant women. And recent statistics have shown that about 12 million pregnancies, you know, are threatened by malaria, and most of which are in sub-Saharan Africa. And that Nigeria and Democratic Republic of Congo account for almost 40% of world malaria cases. So which make it even much more frightening, and the need for us to be motivated to action in this country. And globally, despite this very bad situation, as we have seen in the statistics that earlier speakers mentioned, as well as the ones that I've just mentioned, we also need to be encouraged, you know, that really addressing the problem of malaria is possible. As we can see that about 1.5 billion malaria cases and 7.6 million malaria deaths have been averted between year 2000 and 2019 due to efforts at the global community. So next slide, please. So control and elimination of malaria, whether in Nigeria or in Africa, is in line with the global malaria control strategies, which hinge on 3 4 call interventions. You know, early diagnosing, prompt and effective treatment. It means when someone is ill of malaria, you know, early contacts with healthcare providers to really say, oh, this is the malaria, and also offering the right treatments, you know, is very important. And then, of course, prevention of contact between vector and human through the use of insecticide-treated bed net and other vector control measures are equally very important. And of course, intermittent preventing treatment in pregnancy, in which pregnant women are given a certain anti-malaria drug, you know, after 16 weeks of gestation. We help to clear the parasite, especially P. falciparum, from the placenta, which of course we know lead to negative birth effects, intrauterine retardation, low birth weight, and fetal death. Then, of course, strengthening our local capacities for basic and applied research. And this is where we, those of us in the academia research institutes, come in. And we really need to, you know, build more capacities, you know, to respond to this problem that's increasingly a Nigerian problem. And of course, not just those in academia, but even those in the hospitals and community pharmacy can also be part of it in terms of really getting involved in applied research, right, which can help, you know, in curtailing the burden of malaria and the move towards malaria elimination. The vision of the World Health Organization, as well as the global community, is to have a world free of malaria through set goals, milestones, and targets. And I think if we key into these set goals, milestones, and targets, you know, it is possible for us to have a malaria-free world. The goals are very specific, right? They are very specific. The National Malaria Strategy Plan, which was developed and launched for between 2014 and 2020, you know, had a mandate to reduce the burden of disease to pre-elimination level, and of course, and also to bring malaria-related deaths to zero. But of course, we know 2020 has come and gone, and I'm sure if we ask ourselves, we wouldn't say that we have actually achieved these goals. The strategy for a malaria-free world are built on 3 key pillars. And the pillar 1 is to ensure universal access to healthcare prevention, malaria prevention, diagnosis, and treatment, which is also in line with the universal health coverage. And then to accelerate efforts toward elimination and attainment of malaria-free status. Then, of course, to transform malaria surveillance into call interventions. So the vision of having a malaria-free world, you know, has goals as I earlier mentioned, and they are very specific, and the milestones are very specific as well as the targets. And if you have worked with development partners, you know that these are things that you must discuss when you are talking about providing any intervention. You must set your goals, you must set your milestones, and set your targets, because it enables you to mobilize resources, human and material, financial resources, and be able to work toward a target, and you'll be able to evaluate to see how far you have gone with regard to that. So the first one is to reduce malaria mortality rates globally compared to 2015. And as you can see on the slide, you can see some specific milestones and targets, as well as reduce malaria morbidity, eliminate malaria from countries where malaria is transmitted, and also prevent the re-establishment of malaria in those countries that are already having already malaria free. So this year's World Malaria Day, next slide, the key messages for 2021 World Malaria Day are clear. And I think as pharmacists, we need to take this into consideration, right? The first one is accelerating with urgency. And what this means is that we must do more to protect everyone at risk, despite the global COVID-19 pandemic, which ravaged the whole world in 2000. And of course, the effect is still there right now. And very likely people are organizations, government partners, and other individuals are likely to shift their emphasis from malaria to COVID-19. Then the next key message is realizing success in elimination. And we should believe that despite the challenges posed by COVID-19, elimination is possible, and we should continue to remain on course in doing this. And that when we invest in malaria, in terms of the control and elimination, the impact will also be very beneficial to other current and future diseases. And the next key message is securing global health. Ending malaria will strengthen our fragile health system. And you can, if you do a survey to look at households, impact of malaria on household, community, government, and even private sectors, you will really see the negative economic impact of malaria, and how it also affects our healthcare system. Where to the extent that if you go to any outpatient clinic, you will see that not less than 30 or 40% of those who come may be malaria-related cases. So if we end malaria, it means we can save those resources, and plow them into other areas, of need. And then, of course, the last one is engaging and harnessing the power of youth. Yeah, today's youth, as we are told, as we continue to hear, continue to remain the future of any generation. And we really harnessing the energy and zeal of the youth in the fight against malaria will bring a positive end. And I think I would like to call on the young pharmacist group, to take up this challenge, are key into this fight against malaria, and channel much of their energy towards eradicating malaria in Nigeria. So the next slide is having looked at the burden of malaria and the global effort to end malaria, with partners, government, and agencies working together, to make sure that these set goals and milestones and targets are met. Where do we come in as pharmacists? We, as we know, we continue to remain a key member of healthcare team, and we play crucial role, in global health issues. So as pharmacists, I believe that we have, several roles to play, depending on which area of pharmacy that we find ourselves. For those who are in research or scientists, they have a lot to do in the area of research and development, developing new tools, medicines, and other commodities that can be used in the prevention, control, and elimination of malaria. Then as clinician, hospital pharmacists, healthcare provider, we also have a lot of roles to play in making sure that anti-malaria drugs are used appropriately, and that we are able to monitor to see that the resistance to existing anti-malaria drugs are contained, and that we ensure that we also monitor even the adverse effect that results from the use of anti-malaria, as well as several other clinical functions. Public health experts. This is one area pharmacists have not really gained so much for. For those of us who venture into the development sector, we have seen the huge opportunities that pharmacists can play in this area, because as a pharmacist, you are a trained scientist, a trained researcher, trained healthcare provider, and we are also administrators, and all of these expertise we can bring to bear in public health domain. A lot of pharmacists are doing many great things globally and even in this country. But I think we should, if we can harness this aspect, right, so we can also become more visible, and much of the things we do, in our professional practice can be operationalized within the public health domain. Also, administrator, policymaker, and implementer. We have pharmacists in high positions of authority, both at political and appointees and all of that, and they can, leverage their position, and really contribute a lot in the fight against malaria. So I wish to therefore now recommend that pharmacists to unleash her strengths and remove all self-limiting barriers to achieve her full potential. So we have a lot of energy, a lot of expertise, a lot of capacity to do a lot of things. But I think for a very long time, or can I say traditionally, we have been very conservative, but I think we can do a lot if we remove those self-limiting barriers and being function within the health system itself. And on that note, I may bold to say that everyone is looking for a pharmacist to solve health and developmental problems. So why don't you take up that opportunity, especially in the fight against malaria, and really see how we make malaria end on our world. So on the final note, I would like to say getting rid of malaria in the world will lead to healthier, more resilient communities that are better able to thrive, prosper, and confront new health challenges as they come. Thank you very much for listening to me. And I do hope that this short presentation is impactful and everyone will benefit from it.
Thank you very much, Professor Enato, for that brief and concise delivery. At this point, we want to move straight to our panel discussions. And the first on the list is Dr. David Aje, the Dean of the Faculty of Pharmacy, Delta State University, Abraka. He will be speaking to us on the line between malaria and COVID-19 symptoms and dangers of self-medication with COVID-19 drugs. And for those of us who do not know who Dr. Aje is, permit me to briefly introduce him. He's one of the most humble persons I've seen, pharmacists I've seen, despite his achievements. He's a clinical and public health pharmacist. He's the pioneer ACPN chairman, Delta State. He's the chairman, Faculty of Public Health Pharmacy, the West African Postgraduate College of Pharmacists, and is the current dean, the Faculty of Pharmacy, Delta State University, Abraka. At this point, I want to call on Dr. Aje to take us through this slide. Dr. Aje, please.
Let him go ahead and unmute himself. Dr. Aje, please kindly go ahead and unmute yourself, sir. Dr. Aje, please unmute yourself. You have been permitted to do so. Dr. Ejiro, can you ask him to unmute himself? He has been permitted to do so. No, he's a co-host.
I tried calling him now. He seemed not to be online. So we'll move on straight to our next presentation.
He can unmute himself as been permitted. Yeah.
I don't think it's available.
Or somebody else wants stamp on it. See the name. Okay.
Some technical issues. Just give me a minute. I'll be with you.
Okay, then.
Okay.
Okay.
Just give me a minute. Let me just.
Okay, sir.
Okay, sir.
Just a minute.
Yes,
I'm trying to get a good network. Okay. Okay. We are good.
Please go ahead, sir.
Vice audio. Are you here now? Okay.
Are you still with us, sir?
Can you?
Okay, while we are waiting for Dr. Aja, please, is Dr. Dangiwa around?
Already sílẹ̀ tẹ́lẹ̀. Ó yẹ kó ti sọ fún un.
Is Dr. Dangiwa
Dangiwa.
available?
Ó jẹ́ pé àwọn ènìyàn kó tó ti-
Yes, he's around. He's around. He's on the line. Yes. Do you want to call in?
Sílẹ̀ ìwà rẹ̀ dìnnà.
Can we please take Dr. Dangiwa while Dr. Aja is sorting out his network? Because of time.
Okay, you can go ahead to unmute yourself. It's been permitted to do so.
So we'll quickly take the next presentation by Dr. Dauda Dangiwa, FP.
Are you calling?
Ó kọ́ wọn sílẹ̀.
Dr. Dangiwa is a consultant mental health pharmacist and a clinical psychologist. He's currently a lecturer with the Department of Clinical Pharmacy and he's a 19 graduate of the Ahmadu Bello University Zaria and a pioneer set of the 2004 PharmD conversion of the University of Benin. He also holds an M.Pharm from the latter university, a PGD and MSc clinical psychology. He's currently a PhD candidate with interest in pharmacoeconomics. He's a fellow and lecturer of the West African Postgraduate College of Pharmacists. He was the editor-in-chief Pharma Info, ABU Zaria, and editor with the FMC KEFI, Journal of Clinical Practice. Journal of Clinical Pharmacy Practice. He's a peer reviewer to many local and international journals. Dr. Dangiwa has coordinated many trainings on substance abuse, sponsored by Center of Excellence. He's a secretary and consultant to Parts 2 Committee for the drafting of the standard treatment guidelines and essential medicine list to some states in Nigeria. Recently, he was one of the facilitators of the Empowered Virtual Training for Career Opportunities for Pharmacists in Global Health and Supply Chain. He's a member of the CPAN Pool of Experts, and he was once a regional sales manager with the Nigerian German Chemicals PLC, that's NGC. And he's the current PSN chairman, Plateau States, and coordinator for 4 states for the West African Postgraduate College of Pharmacists. Please, let's pay attention to Dr. Dauda Dangiwa as he takes us on the topic. Our malaria elimination efforts on right track, an analysis of gains achieved and challenges ahead. Dr. Dangiwa, please. We seem to be having a lot of network challenges.
Our advice we move to Ebe.
Yeah. Okay. Let's move on to the third panelist.
Exactly. I think that's the best thing to save time.
Yes. I want to pay attention now to pharmacist Shabi Abdul Razak, the senior product manager, Ebe Pharma. Pharmacist Abdul Razak had his B.Pharm from Unilag in 2003, his MSc Pharmacology from Unilag in 2015-2016 session, and he worked as a regional manager FITSIN 2007 to 2014, and worked as product manager Pharmacy Plus from 2016 to 2018, and presently is the senior manager product management, AOB Pharmaceuticals. He will be talking to us on tackling the menace of anti-malaria resistance, focus on artemisinin-based combination therapies, ACT. Pharmacist Shabi, please.
Please unmute yourself, Pharmacist Shabi.
I've done that, ma'am. Good afternoon, sir, to the chairman of the occasion, and at the same time the president of the PSN, and special greetings to the profs and the retired directors of pharmaceutical services in all distinguished institutions. Am I audible, please?
Yes, please.
Okay, thank you so much, ma'am. At the same time, special greetings to existing and directors of pharmaceutical services across board, whom some have seen, and at the same time to my lecturer, again to Professor Aino. So it is a great privilege on behalf of Herbe Pharma Limited to make this presentation, and at the same time, I'm greatly humbled to say this, although I'm a student, but I just hope that the little I'm able to share will make impact on today's occasion. So permit me to share my screen, and so that I can make the presentation very briefly. Yeah, so yeah. Please, can you see the screen now?
Yes.
Okay, thank you so much, ma'am. Actually, tackling the menace of anti-malaria resistance and in Nigeria and artemisinin-based combination therapy, another concept, is indeed an interesting topic, and we shall be looking at it in sequence. While we take a look at the history of malaria resistance, a very close look at what really happened to existing drug, and how we have navigated to artemisinin-based combination therapy. After which, we equally look at the current challenges we are facing with artemisinin-based combination therapy, with the way forward and possible suggestions. So, introduction, right? Malaria remains an important public health concern today in our country because our country is endemic, and the need to eliminate malaria in Nigeria is very, very important. However, because of concern issues like resistance, fear of therapeutic failure, then huge pharmacoeconomics and burden of malaria on itself, on the populace, both directly and indirectly, people treated, cause for concern that this kind of discussion is indeed a necessity and cannot be overemphasized. Okay, host disabled participating. I've been disabled, please.
Just go ahead, please. Hello.
My screen has been disabled. Am I on back?
Please, continue to share, please. Sorry, continue to share.
Okay. Okay.
Green screen.
Okay. So the fear of resurgence is very important, and like earlier said by the keynote address speakers, the resistance and resurgence of malaria in already established zero zones is a major concern, and the cost of development of new molecules is another concern. But let's take a very quick look into malaria, resistance to malaria. It is actually defined as what? The ability of a parasite to multiply, to survive and multiply and or reproduce after exposure to what? To the therapeutic dose or even a higher tolerable dose. That is a dose, a drug pressure. When you do that and the bacteria or the malaria parasite coexist, then we say what? That resistance has been established. However, that is what? A differential or a confirmation that yes, that the resistance has actually been established by the malaria. At the same time, but some other things actually contributed to this, which we are going to talk later. But among all the strains of malaria, like earlier said too, we have two major strains of Plasmodium falciparum, two major parasites, species of the malaria parasite that have established what? Resistance. And these are Plasmodium falciparum and Plasmodium vivax. And these, out of the 4 malaria parasites that are in human, so these two are of major concern. And out of these two, most and utmost important is what? Is the Plasmodium falciparum. So let's take a look at how it happened in the holding drugs. Immediately after the Second World War, the first drug for malaria parasite was actually chloroquine. And development of resistance to chloroquine and other drugs is actually what gave birth to artemisinin-based combination therapy that we are using now. So how did it develop? It developed, the Plasmodium falciparum developed resistance to malaria, this drug chloroquine by what? By biochemical changes, that is efflux transporters, which actually were lying on the food vacuum membranes and prevent the chloroquine drug itself from going in, so that it could not do what it could not inhibit the process of formation, the conversion of heme to hemozoin. Now, this process, the biochemical changes and the modification on it is as a result of what? Of mutations on those mutations of the genes of those malaria parasites. And these two keywords are important. It is phenotypic and it is mutagenic. Phenotypic in that it is reversible. And this is what we have seen in terms of some of the drugs like verapamil, which is what? Which actually an inhibitor of sarcoplasmic calciums, tend to have ability to reverse the incidence of chloroquine resistance. And this has a correlation even when we are going to talk about other drugs and what? Artemisinin-based combination therapy. The last aspect, which majority of the world have actually not paid attention to, is what? Intracellular calcium, high concentration of intracellular glutathione, reduced form of glutathione. These evidence have actually shown that most of the cells of people that develop, or malaria parasite that develop resistance to chloroquine, had higher concentration of glutathione. And at this point, we all need to know, we all know that glutathione is actually an endogenous antioxidant resident in the liver. And it brings us to questioning that liver enzymes and efficacy of drugs that actually treat malaria in the liver, what do we do concerning them? And what do we equally do to the drugs, the antioxidants used that promote, that work together with glutathione, because antioxidant works at a unity. So, but what we are going to say is that this Plasmodium falciparum has actually, even though it is phenotypic, it is metagenic, it is multi-genetic. So it has like 2-3 different codes. And that is why it could show resistance against drugs that are of the chloroquine families. Now, taking a look at development of resistance to sulfadoxine pyrimethamine, which are actually inhibitors of what? Of protein synthesis in the hexane. The same principle of mutagen also came into cognizance, and this is what? Encoding of the genes of what? Of those enzymes, the dihydroterase synthesis and the dihydrofolate reductase. And in the same principle, 4 different genes were actually seen to be what? To be existent in what? In pyrimethamine. And the concern here is that for every of such genes that actually develop resistance to pyrimethamine also translate to what? To sulfadoxine. And that's why those 2 molecules were actually taken not as a combination drug, but just as one molecule, because when the resistance develop against it, it also comes to the other molecule. So we realize that Plasmodium falciparum has actually shown a very strong tendency of resistance against chloroquine and what? Sulfadoxine pyrimethamine. Now, these two brought into the world the advent of what? ACT combination therapy, which was invented in around 1971. And for the treatment of pyrexia, and after which in the year 2005 was actually introduced. We all know that the basic thing that brought about ACT combination is, one, to tackle the incidence of resistance to malaria, and at the same time to achieve a zero malaria goal of the set Millennium Developmental Goal. Now, it is actually the use of simultaneous use of two anti-malarials of two different mechanisms of actions. That is one of the artemisinin derivative formula family, and which are often notably known for very short duration of action and poor bioavailability, plus a long-acting drugs, and which are maybe the chloroquine family, amodiaquine, and the like that we presently use now. And however, this molecule too at its own. We all know that ACTs are actually recommended for the treatment of all episodes of malaria, moderate, mild, and severe malaria, except of uncomplicated malaria. And as at that time, I remember that in the year 2003 to 2005, the first branch of artemether lumefantrine, which were from Novartis then, more in circulation was by 16 tablet formulation. And when I asked one of the pharmaceutical reps then selling the product that what about this 24, it's when it was reserved for the places where you have multiple malaria parasites prevalence in the Thailand and the area. But now I want to say that right since 2005 to 2007 or 2008, those by 16 formulation are now being eradicated, and we have a complete 24 tablet dosage of artemether lumefantrine, which is actually the preferably first line drug among the ACT combination for the treatment of malaria. This actually tells us that yes, drug pressure has already been established in our society against malaria parasite. Now, it was among the recommendation that all cases of malaria be treated and a fixed dose combination be given, preferably to a co-blister or co-dispense tablet. And this was what led to eradication or prohibition of having a combination of sulfadoxine pyrimethamine separate and artesunate separate. You see that? And this is what we are actually facing. But I may want to say that it was equally stated then that, okay, we'll treat all adults and children, right? And all pregnant women in second and third trimester with artemether. But artemether was actually given a first line drug, while we have other second line drugs. So it's becoming important for us. One, management of artemether as a first line drug in terms of protecting the molecule, and at the same time knowing appropriately when to shift from the first line drug to the second line drug, where we have the artesunate amodiaquine and the artemisinin and piveraquine. I think in Nigeria, both of these molecules are very, very important. And as a pharmaceutical, as a professional, right, the ability to know appropriately when we switch from artemether lumefantrine and move to this becomes very, very important, while also at the same time managing their shortcomings. Now, this comes up in terms of appropriateness of when to recommend it. There's timely dosage regimen intervals of once daily dosage, which is very important, particularly for those drugs that you use once daily. Then, because the two second line drugs like amodiaquine and artesunate, very little evidences of resistance have actually been shown to amodiaquine as a molecule of recent in combination with artesunate, and for the artemisinin piveraquine too, same. So, but once a drug is once daily dosage regimen, it is important for regular timing interval. Then administration with food or glucose base for for amodiaquine, because it is a major concern why people actually tell to move away from it because of the side effect. And at the same time, avoidance of antioxidants containing either food or drug concomitantly used with any artemisinin containing molecule becomes very, very important. Now, what do we really have with artemisinin as a molecule in terms of the mechanism of action and limitations? We all know that the active artemisinin is very active against all phases of the malaria parasite, as it kills all the stages as established by journals. But at the same time, it is very, very short acting. So understanding this molecule becomes very, very important for us. It is very, very short acting. So, and because the molecule as one have a very, very low bioavailability, if we tend to have any issue with substandard drug or a drug that you cannot be certain of its bioavailability, then it is a absolute failure that we are giving only one molecule and not what a combination therapy. Now, how does artemisinin works? It works by what? It possesses an endoperoxide which the heme cleaves, and when the heme cleaves it, it exposes a carbon center free radicals that end up coming back to do what? To alkylate the heme itself and the parasite protein. Now, and this is what actually leads, this is what actually leads to killing of what the parasite. But studies, although the first reported case of artemisinin resistance was actually in Cambodia in around 2007-2008, we have been having reported cases of this, like the keynote address speaker actually gave. But the major challenge is that I think researchers are still on to establish the mechanism of how this molecule actually, how the parasite develop resistance to it. But from laboratory studies, right, studies actually shown that increase or alteration of parasite intracellular stores of some certain protein, which is SACA type protein, which is also related to those proteins that were reacted with by verapamil in, when I was talking about chloroquine. If there is alteration in that, then sensitivity of what? Of the Plasmodium falciparum could be altered, which means that it has a slight inclination or similarity to the method those parasites could develop resistance in the same vein to what? To that of chloroquine. And this brings us to, yes, a major concern that yes, we cannot afford to have what? To have resistance. Like I said, the first case was reported in 2007 and multiple cases 2 years later. Both were attributed to monotherapy, and that was why monotherapy was actually discouraged. However, no specific mechanism of action has been developed. However, researchers have actually shown that resistance to artemisinin can be induced by what? By activation of the SACA type proteins, which were in the Plasmodium falciparum that develop resistance to what? To chloroquine and their family. So what do we do as a challenge now? What do we do? The present challenge we're actually facing is what? Development of resistance as a result of what? Suboptimal dose or
2 minutes more.
2 minutes more. No, okay, sir. And drug interaction. Then pharmacokinetics is one thing that actually came up with most of the artemisinin. So our ability to have novel molecules will be very important in terms of drugs that can attain higher bioavailability in the system. Is very important. Then at the same time, compliance by patient is very important. Then appropriate dosage regimen, timely for all artemether lumefantrine molecule or the single dose. And at the same time, again, administration with fatty food. While I will also say that considering environmental factor, because I was opportune to visit the Makoko site and the largest size of the Lagos here, and I saw swarms of mosquitoes. So environmental sanitation and clearance of bushes is very sacrosanct if we want to eradicate malaria, while at the same time giving rooms for innovations of molecules that brought, increased bioavailability like AHAPN software is one thing we have to look at. So I will tell you that a concerted effort is needed by pharmacists in terms of innovations of molecules and prohibition of substandard products, and pharmaceutical care and advice in terms of how to use, when to use of these drugs become very important. And why I also putting in cognizance prevention of what? Drug interaction. Thank you so much for the time given for the contribution. Just because of time, I'll have to suspend other slides, but if question comes up, we'll take it. Thank you so much for the time.
Thank you very much, Pharmacist Abdulrazak, for your wonderful presentation. We had to wrap up because of time, and no doubt most of us here present are very familiar with your products, especially the soft gel. I think that's one of your fastest largest selling ACT. Thank you very much once again.
Thank you, sir.
So now I want to move on back to our first panel presentation by Dr. Dave Adje. And sorry, there was a mix-up in the team. He's to take us on a malaria elimination effort on right track, an analysis of gains achieved and challenges ahead.
Ready?
Okay. Can I go ahead?
Go ahead.
Can I go
Yes, sir,
ahead?
you can. Yes, sir.
Okay. I want to say it's my pleasure to be here. Pleasure and privilege to be here to address this very, very distinguished audience. And we are speaking on a very important analysis of game. Okay, so I think a good place to start this discussion is to look at some terminology. When we say malaria elimination, what do we mean? We mean interruption of local transmission, reduction to specified parasites in a defined geographical area as a result of deliberate action. All right. Having said, I want to look at control efforts and funding sources malaria elimination program, just to emphasize the present focus. And all of these programs are captured in what we call the malaria strategic plan for various periods. In April 2020, there was the landmark declaration called the Abuja Declaration that was captured by the slogan "Roll Back Malaria," and then funding sources are the U.S. Presidential Malaria Initiative. Okay? And the tools for all of these initiatives are, constants: long-lasting insecticides, indoor residual spraying, treatment of cases, quality assurance of commodities, malaria commodities, and intermittent preventive therapy for pregnant women and children, vector control, and resistance monitoring. So all of these are things that this country and the Ministry of Health have done over the years to ensure that we're able to put malaria in its place. Now, what has been the efforts, the outcome of all these initiatives? And what have we gained from it? 2019, the incidence of portion of infections due to VVAX have also decreased. More people own nets and much more people sleep under nets. Annual death rate has reduced by up to 60%. And 10 countries have been declared malaria-free within this period. And 21 countries have been able to eliminate malaria. So that shows that these efforts have been able to produce very, very appreciable gains. incidence of malaria. You might look at it more closely later in terms of figures, and the 95% confidence intervals are given. This graph shows the decrease. You can see it, it's just going down up to 2019. And that just tells us that the efforts that we'll be making have been producing fine results. This is just to illustrate the tools that have been applied globally and also in Nigeria to ensure that we're able to get all of these things done. Now, what have contributed to these gains that we have been able to achieve? It's important for us to know, because if we are to sustain this gain and even go on to eliminate malaria, we have to work within this framework. One of the things that has been done is aggressive control targeted at at-risk population, the pregnant, under 5, massive investments and funding of malaria by global partners, very massive, unprecedented. Then there's political commitment as epitomized by the Abuja 2000 rolled back malaria by the African tools, like have been able to get insecticide treated nets. There's also indoor residual spraying. And in the recent past, there have been a lot of transparency in disposing of this large pool of funds available for controlling malaria. Transparency, not because we are very good or honest, but because the partners have introduced checks that have ensured that these monies are disbursed properly today. What's the situation? Stress has been stagnated because that decrease in the curves that we have observed has not been sustained. It's like, just being maintained at those points. And why is it like that? Why is it that there is stagnation? One of them is that there is reduced funding now. It's not as it used to be. Globally, it's estimated that we need like $5.6 billion to really take care of malaria, but we can only get 3 billion. There's decreased political commitment, not as committed as they were in 2000 when they made the Abuja Declaration. Our health systems are still very, very weak, and there's poor service delivery. People treat themselves in many African countries and in Nigeria out of pocket. Many of them cannot afford the $700-600 you need to treat malaria. They don't have access to quality care. There's also the issue of parasite resistance. And many countries have reported resistance to artemisinin, and even the pyrethroids that the nets are impregnated with, there's also resistance to these and other insecticides. We also have the problem of poor infrastructure. Many people in this country don't live in good houses. They live in makeshift structures. And you can imagine that it might be very difficult to control breeding of the parasites and the vector under these circumstances. Then of recent, we've also had armed conflicts, insurgency, that has led to large displacement of people, non-immune to endemic areas of malaria. And all these are real challenges that have stagnated the progress that we have made in the recent decades. So when it comes to malaria elimination, what are some critical issues that we need to consider and address as individuals and as a country? We need to try to sustain the gains of these interventions we have made in the recent decade. We need to try to accelerate research and development for new tools for diagnosis, prevention, and treatment of malaria. For instance, we don't have diagnostic tools that can, at present, diagnose low levels of parasitemia. And people with low levels of parasitemia are carriers. and they can spread the infection very, very easily. We also need a next generation of drugs in the making. Please, let's move. Because if the artemisinin-based combination, if we develop massive resistance to them right now, then we'll just be helpless. So there needs to be a next generation of drugs we can fall back to if we have problems with this. We need enhanced community surveillance, just as we are doing with TB now. And we also need people to use drugs rationally, because many people treat malaria, they do self-care for malaria. So they need to be educated and help to use drugs rationally. That will help to reduce the problem of resistance. There also the need to gradually reduce our dependency on donor funding, because if we don't, we are likely to get into trouble and will not be able to do any malaria elimination. If you look at this graph, it just shows you the current funding situation. The local funding by African governments is just 31%. The bulk of the funding comes from the United States, the Bill Gates Foundation, the PMI, and other, so we need to seriously think about how we can, increase funding. For malaria control. We also need to, this graph shows the global percentage of malaria cases. You find from this graph that countries that have less than 5% GDP attributed to healthcare have about 75 cases of malaria, while those that have up to 15% have just 1%. So that shows that we are not spending enough right now on health and even malaria. Control. We need to address issues like this. They're not doing that.
I think the speaker has a network issue. He's back. He's back, yes.
We're talking about systemic corruption. All health programs for which funds are dedicated, we've always found a way to siphon it out. And it's the same thing with this COVID-19 issue. And this is a headline from the Premium Times. It says ICPC commences investigation into the distribution of funds. And it says there were allegations by some that there was financial exploitation and some of the funds had gone into personal accounts. So we have this problem. For us to eliminate malaria, we must address issues like this so that we can put dedicated funds to what they are supposed to be. We also have to try to ensure that people have access to healthcare, and universal health coverage will be one clear way. You look at this graph, you now see that percentage of global malaria cases is highest for people with very low universal health coverage. So we need to try to make our health insurance to work well so that we can just walk into health centers and get treated after paying some small premium. We need to do that. So in conclusion, is malaria elimination feasible? Yes. Is it possible? Yes. Have we done much to be able to make it possible? Yes, we are on the right track. But is it going to be a reality? Are we going to realize all of these issues that we've highlighted, coverage, reduce corruption, and putting dedicated funds to proper use? I want to say in conclusion that all of us have a role to play in this issue of malaria elimination. With pharmacists, healthcare providers, everybody, we need to put in concerted effort to try to see, and the politicians, they need to be more committed, and maybe they need to convene a conference like they did in Abuja 2000 to rejig the mechanism of malaria with the emphasis now on malaria elimination. Thank you very much for listening, and these are some of the references you may need to consult to be able to look at the potential for eliminating malaria in this our generation. I do hope and sincerely pray that we are going to tackle all of these issues headlong, and in a few years we'll be able to say very confidently, just like we did with polio, and maybe chicken. Tackle all of these issues headlong, and in a few years we'll be able to say very confidently, just like we did with polio. Smallpox, yes, malaria is a thing of.
Thank you very much, sir, for that wonderful delivery. Without much time wasting.
Thank you.
Thank you very much, sir, for your presentation. Without much time wasting, we want to call on Dr. Dangiwa. Dr. Dangiwa sent a message that is having network issues. So we'll wait for him for the next 2 minutes. If he's not able to link up, he has asked that he is going to send his slides. So in 2 minutes, if Dr. Dangiwa is still having network issues, I'll be handing over to my co-moderator, Dr. Regina James, to continue with the Q&A and the rest of the program. Please, let's just, we are calling on Dr. Dangiwa. Let's give him the next 2 minutes to sort out his network. If there's no response, then we'll move straight on to the next part of the program.
Only ask Dr. Ajay to stop sharing his slide. Yeah. Dr. Ajay, okay, thank you so much.
Okay, at this point, I want to hand over to Dr. Regina James as she takes over the rest of the program.
Thank you very much, Dr. Ejiro. And we thank all the panelists for what they have done so far. At this point in time, because of time, we want to go into the interactive session as the questions and answer session. But I want to invite some very distinguished pharmacists to come and handle this session. They include the AHAPN National Secretary, Dr. Hafiz. Please, are you in the house? I also want to invite Dr. Ogunjemiyo Bode to come and handle the question and answer sessions. Please, are you in the house?
Yes, I'm around. I'm available.
Not available.
I'm available, Dr. James.
Okay, sir. You're welcome, sir. Please, sir, can you take the questions from the audience and for possible response from the panelists and the presenters? Thank you very much.
Very much, Dr. James, for moderating this particular session. I want to start by appreciating all the panelists and, of course, our revered keynote address speaker for today, Professor Renato. So it is time for questions and answers. And of course, there is also room for us to make our comments. So we are going to approach it this way. If you have a question, kindly raise up your hand, whether a question or a comment. Or
they can decide to increase the salary. That is what they did.
The other way is also to send a message to that room. So if you have any question, you can send it to the chat room or raise up your hand. We want to do this within the next 5 minutes, please. So if you have any question, please raise up your hand or send it to the chat room or comment.
That's how they laugh now.
Comment in the chat. Hello, there is a comment in the chat room asking if participants will get the slides, especially because they could not follow due to poor network. So I'm sure Dr. Bello will see to that. So we are still expecting questions from people. I have not seen anybody raising up his or her hand. Neither did I see any question in the chat room. So we'll just wait for the next 1 minute. Have questions, please. Let's go.
Everyone must have digested the presentation so well. We'll still
Exactly,
give them.
Dr. Exactly. Exactly.
Okay, the hands here. 2 hands are here.
Okay. Okay. Kingsley, please. I can see Kingsley raising up his hand. Please, kindly go ahead and ask your question. Kingsley.
Yeah, thank you very much. Good afternoon. Good afternoon to everybody. And thank you for AHAPN for organizing this celebration. It was quite wonderful. My question is on the vaccine, the malaria vaccine. Okay. In fact, I just saw in the news yesterday that malaria vaccine has been approved. So I just want to find out, is it available in Nigeria? And if yes, what is our position as pharmacists to get involved in the so-called vaccination against malaria parasites? Thank you. Okay, this question is posed to the keynote speaker, Professor Enato.
Pharmacist Kingsley, the keynote address speaker is unavoidably absent.
Okay, so any of the panelists can respond. Actually. Yeah.
So let's take Dr. Ajay, please. Kindly respond to that. Dr. Ajay, are you there?
I would suggest to save time. Maybe we'll take all the questions together and then those are answered. Others will be.
Okay, thank you very much, Dr. Regina. Let's take the second question. Royal eBay. Pharmacist Royal eBay, please. I can see your hand up. Royal eBay. Go ahead with your question. You are not audible enough, please.
Okay, can you hear me now?
Yes, we can hear you.
Okay, so in addition to what Mr. Kingsley said, vaccine has proved against diseases and virus, and the malaria vaccine, according to stakeholders, will be ready in the next couple of months. So I just want to know what the Nigerian government can do to key into that, to ensure that when the vaccine finally comes, we will be ready to ensure that all children are vaccinated. Thank you.
Okay, thank you very much. The panelists are taking notes. Let's go to Pharmacist Chukuma Mwanya. Pharmacist Chukuma, please.
Hello.
Kindly unmute yourself. Yes.
Hello, yeah. Hello, good afternoon, everyone. Okay, I'm not a pharmacist. I'm a journalist.
Okay.
Hello,
okay,
I'm a journalist.
Ahead,
yes, I'm the health editor of The Guardian. Basically, I've listened to all the presentations, and I was on observation. Issue of statistics, figures, as regards to the number of cases and number of deaths and issues around malaria. Like when we talk of resistance against insecticide, when we talk of resistance against the drugs, you know, can we have actual figures? Like, for example, how many Nigerians are living with malaria or had malaria in 2020? And how many Nigerians died of malaria? Because most of the figures we are working with are figures from WHO. Or do we need to conduct surveys? So this is my question. Thank you very much.
Okay, thank you very much. It doesn't seem that they will have any other hand or up. And I don't think I can. Let me just quickly check the chat room. Yes, the chat room. Let me see. Okay, there is a question here. It said, I have noticed a few resistance to ACTs in my premise. I want to know if research has started in that area and what can I do to treat a patient who failed on ACT. So I think we just quickly go to the panelists for them to quickly respond to this because time is no longer our friend. Pharmacist Shabby, please.
Sir?
You are already muted.
Hello, I'm here, sir.
Yes, okay, please go ahead.
Yeah, as regards the question that for the pharmacist that said she experienced a development of resistance to the ACT, the appropriate thing to do is, that is why you have the first line and the second line. If you take a patient's histories and they develop resistance to the first line, the right thing is to go to the second line of the drug and administer, because at least invariably we still have results with that, like we have been seeing around. So if the patient develops resistance to artemether lumefantrine, if you cannot get a good brand of that you are sure that it is not because of the brand, then you go towards dihydroartemisinin piperacin or artesunate and amodiaquine. For researches, data have been collated, but I think it will take some time and we as concern the data's collation and this in our society. Thank you, sir.
Okay, thank you very much. Before Dr. Ajay will also make there is another question in the chat room. The question says, is dihydroartemisinin plus piperacin included in the standard treatment guideline for malaria? Is it included? Then there is another question. How can I give paludrin for treatment of malaria when first and second line fail? So Dr. Ajay or Pharmacist Shabby, any of you? Dr. Ajay or Pharmacist Shabby?
Can I go on?
Yes, please go on.
Okay.
Please go on.
In WHO treatment guideline, the artemisinin piperacin and artesunate are acknowledged. I know that in Lagos State drugs for treatment guidelines, we have artesunate there, and I know the artemisinin piperacin too is there. So those drugs, once the drugs are, or a group of drugs are acknowledged by WHO, most other Ministry of Health nationwide, they are aligned. So selection of choice is based on patient peculiarity and tolerability. That is one thing. Now for paludrin, right, if a patient is not a sickle cell patient or a traveler coming into the country, right, you do not want to subject yourself to everyday use of paludrin. But for travelers, maybe the first thing you do is a visitor traveling to from a zero-free malaria zone to Nigeria. Yet the first thing is if you've been suspected that it's going by, you take a full treatment, then you now take a follow-up with what? With paludrin. And when you get there for the next, I think 2 months or so, or a month or 2 months, you continue. So that is the procedure. But for sickle cell patients here, we know they will be on the course of coverage because of their own peculiarity on daily use of paludrin. So that is my opinion as regards that.
Okay, thank you very much, Pharmacist Shabby. There is a hand up. I think it's just the name of the device that is recorded here. DHIS2LMIS AKS.
Okay.
Are the one.
Okay. Yeah, my name is Jimmy.
Okay.
My name is Jimmy. Yeah, good afternoon, sir.
Go ahead.
Yeah, Jimmy from Akwa Ibom State. I think my question has been overtaken, and that has to do with the inclusion of the hydroxythermicinin and piperaquine in the standard treatment guidelines. Much of you said that is actually included in the WHO standard treatment guidelines. Our emphasis could still be laid that it should also be ensured it is included in her own in-country standard treatment guidelines. So people could actually be encouraged to be bold about talking about the hydroxythermicinin piperaquine combination as an SCT alongside other SCTs.
Okay, thank you very much.
I just wanted to add, my question was taken already. Thank you.
Okay, thank you very much. Before I take Pharmacist Ugo Christopher, there is a comment, someone has sent in a comment from Sierra Leone, and the person said, thanks for the presentation. He said there are some cases of resistance around Sierra Leone. He's now saying, will a superior product be available in due course? And what is the status of the vaccine? I think the issue of vaccine has been sorted out. The person is also requesting for the slide. Then we have one here. This question says, I have seen resistance to first and second line drugs. What is your advice? So I think Pharmacist Shabi should just address that. Resistance to first and second line. What is your advice?
Yeah, sir.
Okay. Yes,
thank you so
please
much,
go
sir.
ahead.
Yeah, for resistance to first and second line, if there is no, according to WHO, you take a recourse back to quinine, and that has to be managed by established hospitals, because maybe for the injection or for the oral tablet by whoever. So that is still a recourse, because that has shown evidences that no resistance yes to quinine. So that is what I may want to say. Although there are other drugs, but tobacco and proguanil, but I'm not sure those drugs are actually here yet, or they have actually been in circulation. So for whoever developed resistance to first line, second line, and possibly among the second line, amodiaquine, which I doubt, then he or she goes back to what? To quinine for treatment. But at the same time, again, if you can analyze the parasites, in some instances, if it is ovale or vivas, there is still tendency that in some instances you can still end up seeing that you go back to other lines, which I don't really want to say, but because we have seen clinicians, doctors telling us that even after some time, they still go to chloroquine. She understands. So analyzing the microscopic analysis also important. Microscopic analysis is also important. But if you develop resistance to the first, second line, then go back to take quinine for that period of time. Thank you.
Okay, thank you very much. I think we'll just take the last contribution or comment from Pharmacist Ugo Christopher. Pharmacist Ugo Christopher, please unmute.
Yeah, thank you very much, the panelists, for a good presentation. Some of my questions have been attended, but the last one I have in mind is the issue of the pharmacoeconomics of malaria management. I'm very happy that one of the panelists has said that is an expert in pharmacoeconomics, and at the same time, the elder pharmacist. My concern is about the level of infection of malaria in the country and the cost of management of malaria. I wouldn't know whether Elber have any plans, because their products, especially the Amatem Fort Gel, is a very widely used product, but the cost is enormous. And at the same time, I wouldn't know whether I have any plan. They might be talking of issue of manufacturing in the country to bring about the reduction in cost, so that other pharmaceutical companies should at the same time live in line with them, because we saw that most of the clients or people being infected with malaria, the major issue in terms of malaria management, if you are looking towards elimination, is the cost of treatment of malaria. Please, I wouldn't know if they have any other plans to ensure that affordability in malaria management will be attained to enhance elimination, total eliminations. Thank you very much for good job done.
Okay, Pharmacist Shabi, any response to that?
Yes, sir. I want to thank the last speaker and every other speaker very well so much for their interest and support for every product. I will thank you all, even including PSN and everybody, ACPN, AHAPN, and everybody. In terms of making it more affordable, one is that we have actually tried to introduce hospital packs of our product SKUs, the soft gel, which is very, very affordable, and I think sells as low as even some common tablets, which ideally shouldn't be. That is one. Then I think if you are in an hospital environment and the likes, yes, we do that. We also give support programs and for every retreat and all these things. Malaria treatment program. At the same time, again, evidently, you see, as a progressive and an indigenous of the country, right? For sure, plans are on the way to establish our factory. That we have some factories, but that will go into production of artemisinin and the tablet formulations. Plans are on the way. Our directors are actually working hard towards this. So all we need is the political will of the government and the support, yes, to harness this. So there's no doubt we are working on that, and very soon you will have a good story to tell about that. Thank you so much, sir.
Yes, thank you very much for your response.
Thank you, sir.
The national chairman AHAP, Dr. Kingsley Amibo, has actually answered the question raised by Mr. Chukuma. The answer is actually in the chat room, saying that there are estimated 100 million cases of malaria with over 300,000 deaths per year in Nigeria. So it means we have data. And malaria contributes to an estimated 11% of maternal mortality in Nigeria. So I think that actually takes care of the question asked by Mr. Shukuma. So it is on this note that I want to hand over to Dr. Regina. Dr. Regina, please.
Yes, thank you so much for the questions and for the answers. Due to time constraints, we will take the closing remark from the national chairman, Association of Hospital and Administrative Pharmacists of Nigeria, talking about Dr. Kingsley Amibo. Please, can we have your closing remark, please?
Yes, thank you so much, my able secretary to the Drug International Committee, Dr. Regina James. Thank you all. I want to appreciate our keynote address speaker, Professor A.F. Enato, for making our time to be here this afternoon to deliver the keynote address. We actually expected our highly revered president to come around, but for some reason he was not able to come. But we appreciate it. He's always been there for us at AHAP. We appreciate our distinguished panelist, Dr. Ajay David, who, despite all his time schedule, has given us time to be here with us this afternoon and to deliver a very, very stimulating lecture and address to us. We also appreciate pharmacist Shabi Abdurazak from Epic Pharma for a very thought-provoking lecture. We appreciate every one of you that came, distinguished professors from various universities and our colleagues from various hospitals, fellows of the PSN are here. Appreciate all of you. We thank you for your various contributions. And I assure you that this lecture will not end here. We're going to escalate this lecture to appropriate authorities. Thank God that the media people are here. My very good friend, the head editor of the Guardian newspaper is here. I'm sure he's going to write what I've seen today to the Guardian health section. I appreciate other journalists.
Thank you very much, Chairman.
Thank you so much. God bless you all. Thank you.
Thank you, sir.
Thank you very much, sir. As the chairman has said, I want to bring to our notice that this program, some people were actually behind the scene, and that is members of the Drug Use Enlightenment Committee. And at this point in time, I want to call the vice chairman of that committee to give a vote of thanks, talking about pharmacist Mrs. Susan Ayetoro. She is a fellow of WAPCP.
Good day, everyone.
Thanks from you.
Yes. Thank you, my dear sister. I appreciate everyone that has been on this platform since the beginning of the program. First of all, I want to appreciate God that has made today a reality. One thing is to plan, and another thing is to execute that plan. We thank God for the execution, and we thank God for today. Today, we are marking the World Malaria Day by this webinar that we are doing now, and we have had our various speakers, the keynote address speakers, and other panelists. So, on behalf of chairman and members of Hospital and Administrative Pharmacies of Nigeria, I'm saying thank you to everyone. And the Drug Use Enlightenment Committee also, we are saying thank you to everyone for making today a reality. We are thanking our president of PSN. He has been with us in spirit and is a good man. Mazi Sam Oabua, MON, OFR, and FPSN. Thank you, sir, for always being our father. We thank our keynote address speaker, Professor A.G.A. Enato of the Faculty of Pharmacy, UniBen. We thank you so much for your time. We invited you and you did it. You really did us honor by coming. Thank you and God bless you, sir. And other panelists here today, Dr. David Ajay, a fellow of the Postgraduate College of Pharmacists and Dean Faculty of Pharmacy, Delta State University. We appreciate you also for your time and God bless you. And Dr. Davda Dangiwa is also a fellow of Postgraduate College of Pharmacy. We thank you for coming. And Pharmacist Sabi Abdurasak, Senior Products Manager, LB Pharma Limited. We thank you also for coming to this program and for your presentation. We thank all fellows of Pharmaceutical Society of Nigeria that have been here since morning, all fellows of Postgraduate College of Pharmacists that has been here also, all retired director of pharmaceutical services present today, all our colleagues in and outside Nigeria, our own Teresa Pams, we thank you for making today a reality. We thank all non-pharmacists that has been with us from the beginning of the program this morning, and we thank the journalists also for joining us. We bless God for today, and we say thank you all, everyone, that 2021 World Malaria Day is a reality. Thank you, sirs. Thank you, ma, and God bless you all.
Much, ma, for that very wonderful vote of thanks. At this time, we want to bring the program to an end, and we want to call for a closing prayer. I want to call upon Dr. Adesina Simeon. If you are here, please, can you take us on the closing prayer? Okay, since Fam Adesina is not here, can we call on Fam Christopher to take the closing prayer? Fam Christopher, are you around? Since he has also left. Okay, let's open it. Can anybody take the closing prayer then?
Shall I pray? Shall we pray?
Let's volunteer and take the closing prayer.
Okay. Shall I pray?
Pray.
Let me pray. Okay. In Jesus' name.
We just thank you for today. We bless you. We magnify your name. Are you hearing me?
Yes.
Okay. Father, we thank you for today. We bless your name from the beginning to the end. You are with us. The program was a success. We bless your name. We that witness this year World Malaria Day, we pray that we witness more in Jesus' name. Amen. And all that the speakers and everyone has said, we pray that God Almighty will make this nation to be a great one in Jesus' name. Father,
Amen.
Association of Hospital and Administrative Pharmacists, for how far you have taken us, for all pharmacists and other healthcare providers in Nigeria, for what we have been doing concerning management and COVID. Father, we bless your name. As we are closing today, we commit everyone to God's hand. Go with us, be with us, and let your name be glorified in our lives. In Jesus' mighty name we have prayed. Amen.
Amen.
Thank you so much, everyone. Thank you so much.
Thank God for the successful program. Oh, thank God.
Thank you for this very great time. May God bless you.
Thank you all. Thank you all.
Thank
Dr.
you.
Bello,
Thank you, my chairman.
Thank you so much.
State
James.
chairman.
Dr. James, thank you.
Dr. Nedo, thank you.
Thank you.
Thank you all.
Dr. James. Thank you, everybody. Our chairman.
Dr. Amibo,
Thank you so much. Yes.
congratulations.
Thank you.
Dr. Amibo, thank you very much.
Dr. Amibo.
God bless you.
Congratulations for a success of the day.
I appreciate you. God bless
You can sleep. You can sleep tonight, Dr. Amibo.
Not be small sleep. Not be small sleep. My chairman, not be small sleep.
You that you allow us sleep. You didn't allow us sleep.
Everybody can sleep now. Where?
Dr. J.
Thank you.
Thank you all. Thank you. God bless you all.
Where is Dr. Ejiro? I woke up.
Ejiro, where are you now?
I woke up to see how many messages on my phone. I said, what is happening?
But we thank God for the success.
All is well that ends well. All is well that ends
For
well.
the success.
You people ask too much.
Eat free.
God see you. I do well.
We thank God.
Appreciate everyone.
We thank
Come in,
God.
Come in.
Okay. Dr. Regina, well done and God bless you. Dr. J.
Dr. James, thank you. Dr. Nedu. Thank you. Thank you so much.
Dr.
Thank you so much. Dr. Ejiro, thank you.
Dr. J, I'm sending greetings. So, Dr. Ejiro.
Dr. Ejiro is
gone.
Thank you, everybody.
Wow.
Ejiro,
Thank God.